Hello, everyone. Thank you so much for joining us. My name is Ava-joye Burnett, and I'm so pleased to serve as your moderator for this very special podcast series called Johns Hopkins Medicine's Journey for Women of Color. As a journalist, I know the importance of trusted sources of information. That is why I'm so excited to moderate this special series devoted to sharing the latest up-to-date information on 3 health issues of importance to women of color. This year's series will feature discussions on ethnic skin and cosmetic surgery for women of color, menopause for women of color, and what women of color should know about multiple myeloma. All 3 will be released in April in recognition of Health Disparities Month. I hope you will find some time to plan to listen to each of these podcasts because they're so good, featuring Johns Hopkins Medicine physicians. In this particular podcast, I will be discussing ethnic skin and cosmetic surgery for women of color. My guest today is Professor of Otolaryngology, Dr. Kofi Boahene, who serves as a facial plastic and reconstructive surgeon. Thank you so much, Dr. Boahene, for being here with us, and welcome to the program. I cannot wait to get started with this. So I see you are an otolaryngologist and not a plastic surgeon. In preparing for this was my first time hearing about an otolaryngologist, and I had to ask you for help to pronounce it. So what is the difference between an otolaryngologist who practices facial and reconstructive surgery and a plastic surgeon?
Wonderful. Thank you today. It's a pleasure for me to join you and your audience. Just a slight background and maybe correction in terminology.
Sure.
In surgery, we all start on the same level. You learn what we call general surgery principles. And then after that, you decide what you want to specialize in. So people take different pathways to get to different pathways. So I am a plastic surgeon. I'm also an otolaryngologist, but with plastic surgery, my focus is on the face. So then I'm a facial, plastic, and reconstructive surgeon. I would do work in an entire body, but most of what I do almost always ends on the face. So I may take a bone from the leg and use it to fix the jaw. I may take skin from the arm and use it to fix something on the face. So that's what a facial plastic surgeon is. And then we have what people terminology-wise know as plastic surgeons. They tend to be what we call a general plastic surgeon. And they are trained to do everything on the entire body. But of late, they tend to focus on shoulders down. In fact, the father of plastic surgeon is a guy called Harold Gillis. And he's from New Zealand originally. He is the one we always give credit for starting the specialty of plastic surgery. He is an otolaryngologist. That is a little bit historical background. Yeah. So otolaryngologist means you work on all the senses of the face, and our specialty tends to be in the head and neck region. But then beyond that, I specialize in plastic surgery of the face.
Okay. Why did you choose this particular specialty?
The face is who we are. It's our identity. It's a very delicate place. It has all our senses, your vision, your hearing, sense of smell, taste. It's all in one place. And when we get up and we look on the face and we know who we are reassured. So it takes some delicate skills to work on the face. And my background training is in the head and neck region. Taking cancers out, fixing broken bones. So it's an easier, simpler transition to just focus on plastic surgery in that region.
You said it so perfectly that this is where people see themselves and identify others. I wonder, what is it like when you walk into a room and you have to start a process of reconstructive surgery or helping a patient who needs for their face to be healed? What is the process like from seeing them to working on them to their end result for that patient in particular, because that's their identity?
It is true. It's a very, very good question. You want to connect with people, right? When you're working on someone's face, you don't see them as patients. You see them people. So number one, we have something that we call form and function. Function of how your eye blinks to allow you to protect your eye, how your nose remains patent so you can breathe, even speaking. Those are functional things. But form is, I look like a human being. I look at myself. I look more aged than I want to because of this disease process or that disease process. So when you come to see me, I'm just seeing you at a point in time in your history of a life that started before I ever met you. So usually there are talks about who you are, what you do, things you like. I need to get a sense of your personality. Sometimes if the face is really deformed, we want to see pictures of your childhood. And if it's not deformed and you're coming to see me for vain stuff, you come with pictures to tell me I want to look like when I was in high school or 30 years, and I may tell you are crazy, but I can do a better form of you. So you want to connect with people and see who they are, and then you try the best to try to get them as close to who they were before their disease process or injury happened.
Okay, I want to talk about the more traumatic cases where there is disfiguration, possibly because of trauma or an accident or maybe some genetic issues. What is that like for the patient when they're finally able to see themselves in a better light? It's got to be emotional.
It's absolutely emotional. The first time you hand a mirror to someone who has avoided a mirror for a long time because maybe as a result of a brain tumor, their face is paralyzed, they can never smile, they can't show emotion. It's a powerful thing. And for me, it's probably one of the best times of my career when taking care of someone, fix their face. It takes 6 months to see the results, and you hand them the mirror and you see them smile for the first time. It's incredible. For the patient, it's an incredible thing. For the surgeon, it's incredible. But for patients, it's a psychological process. There's a lot of psychology behind. Just yesterday, I talked to a patient who's from Colorado. I fixed her face about a year ago from brain tumor. She has not smiled for like a year. And she always felt that in public, people are looking at her strangely. And now she can smile again. And she's telling me, I still feel like I'm deformed, but when I look in the mirror, I see I look great. The mind is doing tricks on her, and the two have to come together. So there's a lot of psychology behind this.
I think of when people say you have a great smile or you look great today, we often take that for granted. And there's this app at work where they encourage you to do certain things so that you could get additional points if you're walking or if you're eating healthy. And one of the things on that app is how do you feel today? And they do them with emojis. And the last
Yes.
one is a big smile. So I am now connecting the two, that the smile is a part of how you see yourself, but also how you feel.
Absolutely. Of all the emotional animations that we do, the most powerful one is a smile. It's been studied. When you smile, there's a chain reaction. The person who sees the smile smiles and it smiles back. Fake smiles don't do those things. Real smile, we call them Duchenne smile, where you see the teeth and your eyes squinting. Very, very powerful.
Oh, wow. I love that. I want to get into some of the meat of why we are here today, because this is a podcast about health disparities and how they affect specifically women of color. What about the role in genetics in women's skin?
In general, the structure of the skin is the same for everyone, regardless of race. The structure is it. The composition, the thickness of layers, how it ages, how hormones affect it, that's different. In the past, when race and skin became an issue, people started slanting and not using race to describe skin and started using the term ethnic. So you start thinking about ethnic skin. I like the term ethnic skin, but it doesn't tell me anything about how someone's skin is going to behave. Because everybody has some ethnic background in them. We are a mixture of the genes who we are. We are a mixture of how our hormones influence those genes and how they are expressed. But we are big respondents to our environment. So we tend to use more skin of color to describe how the skin responds to the elements in the environment and how it ages. That sort of bears with what we are talking about today.
So let's dig a little bit deeper into that with regards to the skin and how it ages. Is there a difference, or how is it different? How does the skin with people of color, how does that age differently than white people?
Skin of color is not uniform, it's very broad and diverse, right? There are two parts of aging of the skin, what we call intrinsic skin aging. Everybody's going to go through it, it's just a matter of time. And then the extrinsic is how the environment affects your skin. This is where skin of color, there's a difference. For example, someone with darker skin is programmed to protect themselves better against UV light and photoaging. You would find that photoaging doesn't occur quickly and severely in people with darker skin. So that's one significant difference. We all have about the same number of what we call melanocytes, cells that make pigment, but each cell will package more melanin in the skin of color versus somebody of a Caucasian background, which means photoaging is slower the more melanin you pack in your cells versus if you have light. So someone with Caucasian type skin may have photoaging quickly, fine wrinkles, loose skin very earlier. Someone with skin of color may not see that very early. Skin of color may have more elastin, so they don't wrinkle loosely quicker versus the other. On the other hand, because of the amount of melanin you have in skin of color, it will succumb to pigmentary changes. So hyperpigmentation will be more prone to that group of patients versus Caucasian patients. So that's how we see the differences. So skin of color may be thicker. As a result, you see more folds, deeper lines, jowling because it's thicker, a little bit heavier, differences in both parts of the spectrum.
I want to ask you about a term that I heard you using, photo aging. In
Yes.
this case, does photo stand for light?
Photo starts for life, and really the light element that we are talking about is UV light. That's what breaks down our cells and causes the damages of aging that we don't want.
How can you prevent against that, minus all of the expensive products that we see celebrities using? What can everyday people do to prevent against photo aging, regardless of your race?
So regardless of your race, even if you think you pack a lot of melanin in your skin, you still are exposed to the UV light and you can have damage. Avoiding excessive sun exposure, protecting sun-exposed areas, taking in a diet that is balanced, that keeps you from fluctuating in how much tension you put on the skin, having a diet that has a lot of water in it so your skin holds moisture, preventing things that are abrasive to the skin because your skin will have to respond to it. Diet that is high in antioxidants that minimize stress injury to the skin. So these are all under what we call extrinsic factors of aging that you can control. The genetics and hormonal changes you can't control so much, comes with time, but the extrinsic ones you can control.
I want to talk to you about hyperpigmentation. Earlier, before we got on, I was asking you about these particular things that affect specifically women of color. For me personally, if I get pimples, there are marks that end up remaining for a very long time. Like they don't go back. It seems as if they take a very long time to disappear. Why do people of color see hyperpigmentation?
So that type of hyperpigmentation is what we call post-inflammatory hyperpigmentation. Inflammation happens to the skin. Inflammation is a normal response to something that is happening in your body. And if it happens in the skin, your inflammatory process tries to respond to correct or fix it. After the inflammation, the side effect is the hyperpigmentation. You can't take the good and leave the ugly. The good meaning you have more melanin to protect you against the UVA, right? The fact that you have that amount of melanin means that if there's any inflammation in the skin, that melanin would tell you that something happened. And that's why you have post-inflammatory hyperpigmentation, the more melanin you pack in your skin. And so acne is one of them. So if you have an acne injury, it's like you have collection of oil under the skin. The cells of your body would respond. There's an inflammatory process. And as part of the response to the inflammation, melanin is put there to try to protect the skin. You get hyperpigmentation. Then we have to treat that after the acne is sort of calmed down.
I have never heard someone call acne an acne injury, but that's what it is because something is happening to your body that is not normal.
Absolutely.
That is great. So, how do you treat hyperpigmentation?
You want to know the cause. For people of skin color, one most common cause is acne, actually. Acne has hormonal fluxes. There's a link to hormonal influence and some lifestyle choices. And so usually when I see a patient with a lot of acne, I try to treat the acne first because otherwise you treat the hyperpigmentation and the underlying cause is still there. So you try to kind of calm down the acne and then treat the hyperpigmentation. So ways to calm down the acne, there are different ways. One question is that for females, it may cycle with their cycle. And so you see that during their period, it flares up. And so some of the treatment is to try to break that cycle. We may put them on low dose antibiotics before and after their period to keep that down. And then once we've gone like 3 cycles of calming them down, then we treat the hyperpigmentation. A treatment of the hyperpigmentation by itself, you're trying to calm down the added pigment to the skin, and there are different agents that are used. A big part of it is a lightening cream, agents that tell the melanocytes stop making the melanin, or the melanin that is already being produced starts breaking them down. Different regimens.
So that would be a topical treatment?
Yes, that would be a topical treatment. There are oral treatments that you take to try to calm down the cause of the inflammation, and topical treatments to correct the after effects of the inflammation.
And I must be more specific about what topical is, even though I'm not a doctor. This is just based on experience. Topical means something that you put on your skin, outside your skin.
Correct.
Okay. How long does it take for your skin to return to its normal pigmentation if you have hyperpigmentation?
Number one, you want to eliminate or reduce the insulting agent, whatever is causing it. And then after that, you are trying to calm down the pigmentary changes. It can take as early as 6 weeks. The skin is turning over all the time. Younger cells from the deeper layers of the skin coming to the top. That cycles around 6 weeks. There are agents that we can use to quicken that cycle, just to bring the pigment from the depth of the skin to the surface, and then a topical agent to wipe it off. So if anybody tells you there's a magic pill that will take care of it in a week, they don't know the science behind skin.
6 weeks. 6 weeks. And how about this whole issue of spot treatment? Because if you're using creams on your face to help with that process, should it be a whole face situation or just at certain spots when you have those remaining marks?
You can do spot treatments, because the thing is that if you put a topical agent on your entire face, it cannot discriminate what it treats. It treats everything in this part, right? So if you've had inflammation in some spots and those areas are darker, we want to do spot treatment to that area and then blend things in evenly. So yes, spot treatments are part of it.
I want to move on to another topic, sir. So another issue women have is scarring. What are the surgical and non-surgical treatment options? And do women of color have unique concerns with scarring?
Yes, so let's start with the unique concerns of scarring. Women of color, for various reasons, the way their fibroblasts behaves and the type of collagen they lay down, tend to have thicker scars, are prone to what we call hypertrophic scars, scars that look thicker than usual. And there is some risk of what we call keloids. Keloids will be scars that grow beyond the boundary of the original injury. We know in skin of color that is a little bit elevated. Not to say we don't see keloids in Caucasians. We can see keloids and hypertrophic scars in Caucasians. But because of thicker layers of the skin, you tend to see thicker scars. So what is the treatment of scars? Scars have a bad rap, but I'll tell you, in my work, without scars, nothing heals. Scarring is the normal process of healing. If you injure yourself, there's a cascade of processes that starts and it ends up in a scar, and is the way the body heals itself. Now, we don't want a bad scar. So scarring is needed, but a bad scar is what we don't want. When I see somebody we're trying to treat a scar, there are some features of the scars that we look for that dictates what we need to do. So a scar that you don't like is something that is obvious to people. They look at it, then they can see it. So one is the color. The scar could be darker than the surrounding areas. And if the issue is the darkness, then we use pigmentary agents to calm the color down. A scar can, in the same token, be lighter than the surrounding area, hypopigmented. You cannot make a lighter scar darker. You can make a darker scar lighter, but a lighter scar, you can't make it darker. So then we have other ways to try to make it darker. Sometimes we actually tattoo them. Sometimes there's medical tattooing that would blend the scars in because we don't have any other options. If a scar is unfavorable, meaning when you smile, the lines of your face goes in this direction, but the scar is going in a direction perpendicular to that line, we can use surgery to change the orientation of the scar so it falls in a crease that hides it better. So reorienting scars is one thing we do. If a scar is depressed, as soon as light falls on it, it would absorb the light and cast a shadow. So then everybody sees it. So if it's depressed, we may put something underneath it to push it up to make it even. In the same token, if a scar is raised like a hill, it will reflect light and everybody sees it. So we then have to reduce the height of the scar so it blends in. So in general, we are trying to see what are the features of a scar that makes it stand out so we can blend it in. A good example is what we talked about, acne scars. Acne scars seem to be like divots and they are depressed. So they look darker, not because of the color only, but because they are depressed and they absorb light. So after we treat and blend it in, we may stick something underneath it to push them up so that they blend into the rest of the skin.
Oh, I love that. One thing that came to my mind now, and I wrote this down, in order to avoid a bad scar, do you need a good surgeon, someone who knows how to prevent bad scarring?
No question. You always need a good surgeon for everything you do. But in your face, you got to trust someone who's an expert. Because number one, where you put the incision to make the scar in the first place is important. And number two, they should be able to anticipate how they think your skin is going to heal and change what they do to modify that. So, for example, I may see somebody and I know this person is not going to scar well, and they want the facelift. The incisions that I may use for a Caucasian may be totally different from what I would do for them, or the recommendations may be different. For sure, that's important.
Okay. I also want to talk to you about this issue of the skin tags. Are skin tags maybe little molds on people's faces? Is that unique to people of color?
No, not unique to people of color, but we tend to see it more. Now, how they happen, there are tales about it, how they happen, and nobody really knows. There is something about the skin that we call when a cell in the body has reached its limit and it's not functioning well, there's a term we call apoptosis. Funny word, it means it's a natural cell death. The cell kills itself. So new cells kind of do what they do. There are some cells that in the skin that become what we call senescent. They are not doing what they're supposed to do, but they won't go through this natural cell death and they just sit there. And then when they are there, they affect the other normal cells and they cause these aging processes. We think that may be part of what causes all these changes in the skin, including the pigmentary changes, including what starts looking like these skin tags. So do we understand how they work very, very well? No, but we think all these cell types that are not programmed to die off just overgrow and cause some of these things. So we tend to see them more people of color, but they can affect Caucasians as well.
Okay. And for people who may not know what they are, Morgan Freeman has them. I have them on
Correct.
my face, and I've had them even since I was young. So I'm assuming that there is a genetic issue with skin tags as well.
Yes, there is. Almost everything that we express in our body and face is a picture of our blueprint. So there's a genetic predisposition to them too.
My blueprint was my grandmother.
Wonderful.
My mom
Wonderful.
doesn't have it, but my grandmother does. I want to ask you about healing. What are the unique characteristics in the healing process, especially for people of color?
Healing process is very programmed. It goes through the same steps regardless of everybody.
Okay.
But based on the thickness of the skin, how your fibroblast behaves, the process may be slower. The thicker your skin, the longer it takes things to heal, more swelling, thicker scars. So we have to kind of anticipate all that when you injure yourself or when you have surgery to factor that in to be able to tell you your end result. A good example is when we do surgery on the nose. The nose has actually different thickness of skin. This is a very good example. The upper half of the skin may be thinner skin, the lower half of the skin may be thicker. So when you do surgery on the nose, you see the upper half will heal quicker and the lower half will take longer. And sometimes we tell people it will take a year before you see your results. So that kind of gives you a sense of skin thickness and the healing process.
Okay. As you were describing that, I was looking at my nose to see if I could see a difference in thickness. You also focus on tissue engineering and wound healing and facial paralysis and restoration. We touched on this a little bit earlier. Can you tell us about your work and special consideration you need to pay towards patients with ethnic skin when you're touching on those more severe types of surgery?
Just to touch a little bit about tissue engineering, because I have such an interest in wound healing,
Yeah.
and among people of skin of color, there is the preponderance of keloids. A lot of the work that I've done with tissue engineering, collaborating with some of the leading tissue engineers at Hopkins, is looking at trying to make a model of keloids in a lab setting. in a research setting to see how we can change and influence how things heal. And so that's the extent of my work in tissue engineering. But tissue engineering is a fascinating area of research. When it comes to facial paralysis, that's probably what I've become known for. With paralysis can happen for various reasons. The most common reason is people with Bell's palsy. They are fine one day, they wake up the next day, the face is not moving. Angelina Jolie had it. It became a very popular thing because it's a person in the public's eye. Like we said in the beginning, when you lose your facial features and expression, it affects you significantly. We have options to fix people who have Bell's palsy. We have options to fix people who have strokes, that their face doesn't move. We have options to fix people who are born without the muscles to be able to smile. It takes a lot of moving things around, but we can get the face to move most of the time.
Okay. I'd never heard of that phrase, tissue engineering, before today. Good to understand. And you touched on the situation that Angelina Jolie had. What is it called again?
She had Bell's palsy. Bell's palsy is a description for a palsy like a stroke, but it's not a stroke. Your face doesn't move. And it's a very specific kind of paralysis of the face. And it's quick. We think it's a virus that causes it. And most people would be fine one day and they wake up the next day and then the face is gone. It happens to about 40 people out of 100,000 every year, at least in the US. So it seems like it's a small number, but I see them a lot. Most people with that would recover the movement again, but there's always an aftermath, a telltale sign that something happened to the face. That's what we tend to treat to make sure the face can move easily again. So that's the most common reason. But there are other causes for paralysis of the face, and that can be tumor, injury from surgery, or a car accident, or some people are born that way. They don't have the muscles or nerves to be able to move their face. And so we have to come up with options for them.
When you were mentioning the most common cause for paralysis of the face, I thought you were going to say stroke.
Not stroke. In fact, when people get Bell's palsy, the first thing they think about is that they think they've had a stroke. So they usually panic and then they go to the emergency room and then they ask them questions and then they do the test. And usually they rule out a stroke and then come to the diagnosis of a Bell's palsy.
Okay, so I have a long one here for you. So, as an expert microsurgeon, you routinely perform some of the most complex facial reconstruction procedures on the face, including rebuilding of an entire nose, lip, jaw, and facial defects resulting from cancer treatment, traumatic injuries, like we just mentioned, like a car accident, or as a result of birth defects. So please give us some special considerations that you need as a surgeon or that any surgeon needs to be aware of when they're operating on women of color, if there are any special considerations.
Technique-wise, no difference, but outcome and how tissue behaves, big difference. Technique-wise, if we are building the substructure of your face, which is the bone of your skeleton, is the same. Usually we put bones together, we put titanium plates together. Outcome-wise, just like what we've talked about for the past half hour, how the tissues behave, how they scar, should influence exactly what we do. So, for example, there's something that we call pedicle flap. Somebody is missing the tip of the nose for different reasons. I could, in a Caucasian patient, move skin from their cheek by making a cut in the smile line and move a portion of the skin on the cheek to the nose and rebuild the tip of the nose. I would do that in a Caucasian and not think twice about it. I will almost never do that in a person of skin of color because I may build their nose, but they will be left with a very thick scar in their face that is obvious. So, whereas textbooks will tell you where you can move tissue from, a lot of them are based on Caucasian examples and experience. You can't just translate that to someone of skin of color because you have to know how their face is going to scar. And in the central face, you don't hide scars. You can't hide them. Whereas there are tissues that I can move in a Caucasian patient and a patient of skin of color, I wouldn't do the same. Then I want to go to areas that I can hide the scar. I may go to their arm, their back, so that you can move tissues, sew blood vessels, so you can avoid central facial scars.
I want to ask you about doctors of color in this field, if you believe that there are adequate numbers of doctors of color in this field who are sensitive to those disparities and who are sensitive to the fact that you can't take all of the recommendations from a textbook because of the way we may be affected with scarring or hyperpigmentation?
Well, I would say the trend is changing. Definitely inadequate numbers. That's number one. But the trend is changing. When I first entered as a facial plastics surgery fellow training, I could count on one hand how many fellows of African American descent in the country. I could count just on one hand. When we go to meetings, I see them all. We sit on the same row, there'll be three or four of us. That is changing. We are training people more to look at like the society in which we live in. And that's number one. Number two, we're increasingly writing about these topics. So like I've written about topics about what we call ethnic sensitive nasal surgery. That if I'm going to change somebody's shape of the nose, I don't give someone of an African background a Greek nose, or I don't give someone of Swedish background a Middle Eastern nose. So that's an ethnic sensitive nasal surgery. You have to know that person's ethnicity, which is the cultural norms they live in, what is acceptable, what is seen as beautiful, and then factor that in. Our textbooks in the past did not bring that topic at all, but increasingly, that is becoming part of how we train people and what we write about.
So today, rather than being able to count on one hand, how many people of color would you say are now in these conferences who have your specialty?
I'm on the board of American Facial Plastic Surgeons. Well, on the board, there are about five of us. So that kind of is a reflection of how things have changed.
Yeah, and that's just the board. On the flip side of this, I want to ask you about white doctors who are in your field. What should they know? Are you seeing a change in how they operate and how they take what they've learned from the textbooks and flip it to the advantage of people of color?
I think so, in the sense that I don't want to use the word consumer, but let me borrow that. In elective surgery, especially cosmetic surgery, what people want drives what people do. In the past, elective cosmetic surgery was probably thought to be for people who are very wealthy and not accessible to some groups. That is changing. Almost people from all socio-economic strata seek these surgeries. So it's forced everyone in this field to learn what people see as beautiful, how their skin responds to surgery, laser treatment, chemical peels, injectables. So I think increasingly is becoming part of how we are trained and how people take care of patients.
And if we could quickly touch on the finances and putting the elective surgery aside, a surgery that is elective surgery, something that someone does not have to have.
Correct.
Okay, so putting that type of surgery aside, what are you seeing with regards to people who have surgeries that they need to get and their ability to pay, especially for people of color who may not always have access to adequate health care?
Access to healthcare and good healthcare, I think, is the number one thing that influences disparity in outcomes of healthcare delivery. A lot of times we may think, in my opinion, that this group of people don't do so well because they get heart attacks more than others, and we may attribute that to genetics. I think it's probably more access to healthcare than genetics. Fortunately, I work in a hospital that is in a place that takes care of every comer. If you come in and you need healthcare, we're not going to turn you away. The finances of healthcare, I'm not so versed in it, but I would say access is always a big deal. Now, there's one thing to get access, but the second thing to get good care from the person who is delivering it. And usually it comes to being able to connect. And so if you're from different cultural backgrounds and you can't connect, you may not get the right kind of healthcare.
Sometimes it's a hard truth, but it's one that's very important to talk about and to also acknowledge that we're getting so much better, but there is work that still needs to be done with regards to access and disparities. Now, I want to talk about you a little bit. I'm just so curious about how you got into this particular field, because I heard about your book and that it was so well received that when you talk about these things, you get standing ovations in the audiences. So I want to talk about your book, and then also, how did you get to this point to pick this specialty?
So the book is something I wrote in 2016. Actually, I was motivated by a patient's experience to do it. In fact, the patient came to my office and said, "You got to write this book and you just have to do it." That's one of the things that pushed me to do it. The title is However Far a Stream Flows, That's it. But it's a short form of a proverb that says, however far a stream flows, it doesn't forget its source. I'm originally from Ghana. That's my source. I've been privileged to be educated, trained at some of the best hospitals and institutions in this country. And so I don't forget where I came from, those who helped me along my journey to be able to look back and give back. And that is true for me, and I think it should be true for everybody. So that's my background. Now, how did I end up in this specialty? In medicine, we are a reflection of people who mentor us, experiences that we gather along the way. I got into surgery because I like to work with my hands and I like to fix things. It's how I grew up. So I'm not surprised that I'm sort of doing surgery, but there's a story behind it. I could not stand the sight of blood. When I was growing up, I couldn't stand the sight of blood. I have siblings who are doctors. I could see them doing surgery, not me. They could do things like that, but I would run away from it. But in high school, one of my classmates got injured really badly, and we carried him to the emergency room, and I had to hold his face and tamponade off his bleeding with his t-shirt. And that experience changed me. It changed me because I saw that I actually could stand blood when it mattered. And number two, he did not get a good care. It was his face. His face was mangled. I never saw him again. He didn't come back to school. And I thought, I'm going to go to medical school. I'm going to do something about this. And that's how it happened. As far as specializing on the face, I learned to do surgery on the head and neck region. And constantly, you take a cancer out, you cure somebody, and they will tell you, am I going to be able to speak? That means, can you fix my voice box? How am I going to look? Would my grandchildren run away from me when they see me? So beyond just taking cancer and curing people, it became clear to me being able to put people back together for them to have some quality of life was important. So that's what pushed me to specialize on facial plastic surgery.
I love that story. And when you talk about being able to put people back together, in my head, I finished that by saying to make them whole again.
Correct.
And that is the work that you are doing. I am honored to have learned so much from you today as someone who is not a doctor, who does not like blood. I am grateful that I was able to learn from you today. So thank you so much for joining us. Is there anything else that you wanted to add before we go?
I think you did great. I think you covered it all. I can talk on this topic for hours and hours because I'm passionate about it. I thank your audience for tuning in and the opportunity to talk about the subject.
And you were saying you were going to send me the bill later because of all the personal questions I was asking. You could send the bill and I'll frame it at home, okay? But I may not respond with a check.
That's all right. That's good. That's all right.
Dr. Boahene, thank you for joining us, and thank you for joining us today for this special podcast on skin and cosmetic surgery for women of color. It has been an honor to serve as a special guest moderator for Journey for Women of Color. Thank you, Dr. Boahene, for being our guest today. Johns Hopkins Medicine, A Woman's Journey, would like to thank Astellas for its unrestricted educational support of this year's Journey for Women of Color podcast series. If you've enjoyed today's discussion, I know I did, please check out A Woman's Journey's website, hopkinsmedicine.org/A Woman's Journey for information about upcoming free webinars. Subscribe to A Woman's Journey's Insights That Matter podcast series and sign up for A Woman's Journey's monthly email. Everyone, thank you for being here with us today. Dr. Boahene, thank you.
Thank you very much.